This video is about infective endocarditis. What is infective endocarditis? The definition is that it is a microbial infection of the heart valve or mural endocardium. So it's an infection that is obvious and it affects the heart valves or the endocardium of the heart. Most commonly the heart valves are involved, and because of the infection we have the characteristic vegetations. We'll discuss more about the vegetations. The vegetations are actually pathognomonic lesions of infective endocarditis. Now, the next question is, which are the organisms that are involved? So we have a wide range of organisms. The most common one is the Staph aureus. Staph aureus is the most common organism causing infective endocarditis. And the peculiarity is that it is a highly virulent organism and it affects both healthy and deformed valves. So both abnormal and normal valves can be affected by Staph aureus. And it is important in intravenous drug abuses because during their drug intake, the Staph aureus could enter into the veins, and as the veins travel through the right side of the heart, they could cause right-sided endocarditis, infective endocarditis. The next organism is Streptococcus viridans. Now the viridans streptococci, compared to Staph aureus, it is less virulent and it affects deformed valves. It usually does not affect the healthy valves and it causes a subacute type. We'll discuss about the different types of endocarditis later. It causes a less virulent subacute type of infective endocarditis. The third organism is Staphylococcus epidermidis. This is actually a commensal of the skin and it's a coagulase negative staphylococci. We'll learn about that in microbiology. Here what we need to know is it is involved in the prosthetic valve endocarditis. So after prosthetic valve or after valve replacement surgery, the other organisms of importance are, one is the HACCP group of organisms. So what are the HACCP groups? We might have learned about them in microbiology. They are the Haemophilus, A for Actinobacter, C for Cardiobacterium hominis, E for Eikenella corrodens, and K for Kinganella kingae. So these group of organisms are important for infective endocarditis. And then we have gram-negative bacilli. Sometimes fungus, certain fungal infections cause infective endocarditis. And in 10 to 15% of cases, the culture report might be negative. So culture negative infective endocarditis might be seen in 10 to 15% of cases. So having said that, now let's move to the two types. Traditionally, we divide infective endocarditis into two types. We divide it into an acute type and we divide it into a subacute type. Now the characteristics are easy to remember. Acute type is a more severe form, whereas subacute type is a milder form. So with that we can describe it. So acute, it affects even healthy valves. So even healthy valves are involved, whereas subacute only affects the deformed valves. So there must be a pre-existing valvular deformity for subacute infective endocarditis to occur. And acute, it is due to highly virulent organism. So which was the highly virulent organism which we had said? That is the Staph aureus, right? So Staph aureus usually cause acute type, whereas in subacute type the virulence is low. So low virulence or lesser virulence is a more specific term, and the organism is most commonly Streptococcus viridans streptococci. Now the third point is the destruction. So which do you think is more destructive? Of course, acute is more destructive, whereas subacute is less destructive to the valves. Coming to the treatment, usually surgical repairment or surgical valvular replacement is required in an acute type, whereas in subacute type only antibiotics are required. Usually surgical management is not required. However, these classifications are vague and there might be overlap between the two forms. Usually most of the cases fall somewhere along the spectrum between these two forms. And finally, as we expect, the mortality is higher. So higher mortality in acute form compared to the subacute form. So it's easy to remember. The main core points that we need to remember out of these are, one is healthy valve involvement in acute endocarditis, high virulence, surgical management. So these 3 points, and the organisms, Staph aureus, Streptococcus viridans. So these 3 points are important to know about acute and subacute type of infective endocarditis. Moving on to the pathogenesis. So we need to know the risk factors, right? What are the risk factors which predispose to infective endocarditis? We'll divide them into 3 reasons. The first one is conditions which lead to sepsis. And secondly, we have underlying heart diseases. So already existing heart diseases which can predispose to infective endocarditis. And finally, we have some iatrogenic causes such as trauma or prosthetic valves. Now what are the septic causes? Septic causes could be 3 possibilities are there. First one is the infections. Of course, the most obvious reason why, yes, of course, most obviously infections. It could be the skin infections. Skin infections could predispose the coagulase negative staphylococci because it's a skin commensal. And then there could be systemic infections, that is of the lung, involving the GI tract and so on. And the second is surgeries or procedures procedures involving the dental cavity, because dental cavity is a common cell, or the oral cavity is a common cell for Streptococcus viridans. So dental and cardiac procedures itself. And finally, as we had said, the IV drug abuse. As we had said, the right-sided endocarditis by Staph aureus. It's more common in IV drug abuses. Now, what are some of the underlying heart diseases? Obviously, the first one would be valvular diseases, right? And then there could be congenital heart disease. And then there could be decreased host immunity. Or now the valvular diseases, some two examples if you asked, it would be, one is rheumatic fever. Now it is decreased rheumatic heart disease because the cases of RHD has decreased. Now the most common cause is mitral valve prolapse. So a patient with mitral valve prolapse is more prone for infective endocarditis. Some conditions which decrease host immunity, we know the most common are diabetes mellitus and malignancies. So these are actually the risk factors, right? Now, how are the vegetations formed? Let's discuss that. Here we have a normal heart. This is our normal heart. And this is our normal valve. And this is our chordae tendineae. And here we have the valve leaflets. Now, the first event in the pathogenesis of infective endocarditis is an endocardial damage. So, a damage occurs to the endocardium. It could be either due to the pre-existing defect which causes or a damage to the valve which can cause an abnormal blood flow leading to the endocardial damage. And when there is an endocardial damage, what happens is that the subendothelial collagen and extracellular matrix is activated, right? And as a result, due to their exposure, what happens is that they will attract the platelets and fibrins. So platelets and fibrins in the circulation will enter into this damaged area and they will form a thrombus. So a microthrombi formation will occur. So our second step would be formation of a microthrombus with platelets and fibrin. Now, as of now, the microthrombus is not yet infected, right? So it is actually called as a sterile thrombus because bacteria has not yet invaded into the microthrombi. Now, the bacteria, by septicemia or by other methods, it enters into our body and it circulates through our blood and it enters into the heart. And this bacteria will now, here we have our microthrombi, right? This bacteria will now invade into the microthrombus. So bacterial invasion occurs into the microthrombus. That will lead to the formation of infected thrombi. So our third step in pathogenesis is the formation of infected thrombi, which contains bacteria. Now within this infected thrombi, what happens is that the bacteria starts to proliferate. So once again, we have our microthrombi, and on top of our microthrombi, bacterial invasion occurs and the bacteria will start to proliferate. These green colored bacteria will start to proliferate, and on top of them what happens is that there will be further deposition of fibrin and platelets. A further deposition of fibrin and platelets will occur and that will lead to the formation of our vegetations. So that is how the characteristic vegetations of infective endocarditis are formed. That is our fourth step in pathogenesis. What happens to the vegetations? So there are three possibilities. First one is these vegetations can form an emboli and they can embolize. So emboli formation could occur, and because of the sepsis and vegetation formation, we'll have our clinical features, that is cardiac manifestations will be present, which we'll discuss next. Then the valvular damage, which can be seen in the form of murmurs, regurgitant valves, or heart failure. This happens with the formation and development and further progression of the vegetations. Now let's move into the morphology. Let's describe the characteristic vegetation. The vegetations are pathognomonic findings of infective endocarditis. We'll say that in 3 points. The first point is they are friable. Next, they are bulky. These vegetations, unlike that of rheumatic heart disease, they have a tendency, they have the ability to get detached and form an emboli that can get dislodged into distant sites in the circulation. And thirdly, they are destructive. They destroy the endocardium and the heart valve. So these are the 3 points regarding the appearance of vegetations in acute or subacute infective endocarditis. Their location, where are they located? Usually they are located on the left side of the heart, and in the left side they are usually located in the aortic and the mitral valves. As expected, the aortic and mitral valves are more usually involved than the right side or the right valves. And their number, they could be either single or multiple. So that's about the gross features of the vegetations in infective endocarditis. 3 points. They are friable, bulky, destructive lesions found mostly on the aortic or the mitral valves. Now what are the microscopic features? Well, it's really easy, right? So there will obviously be platelets and fibrin, and there will obviously be inflammation. So there will be inflammatory cells, and then there could be bacterial colonies might be visible. These are the findings that we are going to see, especially in an acute infective endocarditis. When it comes to subacute infective endocarditis, in addition to these features, healing may occur. So because of healing, we may see signs. What are the signs of healing? The first one is granulation tissue. Granulation tissue formation might be visible. Or there could be fibrosis, signs of fibrosis, fibroblasts and all may be seen. Chronic inflammatory cells may be seen, such as macrophages and monocytes. So these three will be seen in addition to the platelets, inflammatory cells and bacterial colonies. Now let's move to the clinical features. So clinical features, I roughly divide into the features due to onset, features seen at the onset, then the cardiac features, and then the extra cardiac features. At the onset, there is going to be a high-grade fever. So high-grade fever greater than 38 degrees Celsius, then there could be chills, there could be weakness, GI symptoms, and the typical features that we usually see in a high-grade infection. What about the cardiac features? So obviously the first one will be the valve involvement, right? So valve, there could be a rupture of the valves. There could be regurgitation, which will present, or in examination on auscultation, we may hear murmurs. Now it may affect the myocardium, and abscess formation in the myocardium will occur, and that is actually called as a ring abscess. Why is it called ring abscess? Because of the shape of the abscess. The myocardium will be involved in a ring shape. The vegetations will erode the myocardium. And third one, it may involve the pericardium. It may extend into the pericardium, and it may cause a pericarditis, a suppurative pericarditis. So these are the cardiac features which we see in infective endocarditis. What about the extra cardiac features? Extra cardiac features we actually divide into two subdivisions. There are features due to vascular features, or there could be immunological features. That is due to the activation of humoral and cellular immunity, antigen antibody complexes may be found, and they may get deposited at several sites, and that could lead to immunological features. Now, what are the vascular features? We had said earlier that the vegetations could embolize, right? So because of the emboli formation, what happens to these emboli? They get detached and enter the circulation, and in the circulation, they could dislodge at certain sites such as spleen, kidney or the brain, and they could cause infarcts in these regions. Such infarcts are called as septic infarcts. The term is self-explanatory. These septic emboli, they can weaken the vessel wall of the arteries, leading to formation of aneurysms, and such aneurysms are called as mycotic aneurysms. And thirdly, there is a characteristic vascular lesion by the name of Janvey. Now, Janvey lesions, they are actually non-tender, that is, they do not elicit pain on touch. Macular lesion, they are macular lesions that are seen in the palms and soles. This is the location, they are seen in the palms and soles. They are usually found in infective endocarditis. So these are the vascular phenomena. Now, what are the immune-mediated reactions? The immune-mediated reactions are, first one is glomerulonephritis, that is due to the immune complex deposition in the kidney. What type of glomerulonephritis? Focal segmental glomerulonephritis, which we'll discuss more in the chapter of kidney. Second one, they lead to characteristic findings, which are, one is Osler's node. What is an Osler's node? An Osler's node, it is formed due to the immune complex deposition at the pulp of digit. So the location is pulp of digit. Janvey lesions are found at the palm and sole, whereas Osler's node is found at the pulp of digits. And compared to Janvey lesions, Janvey is non-tender, right? This is tender, that is on touch, it may cause pain to the patient, and they are subcutaneous nodules. That's about Osler's node. And finally, on fundoscopy, when we visualize the retina, we may find hemorrhagic spots. That is called as Roth spot. So Roth spots are actually retinal hemorrhagic spots. Retinal hemorrhagic spots, which are again due to the immune complex reaction. Now, how do we diagnose? How do we say that someone has infective endocarditis? For definitive diagnosis, we use the modified Duke's criteria. So Duke's criteria has two elements. There is a clinical part and a pathological part. So either you can diagnose by clinical criteria or by pathological criteria. The pathological criteria is that either by histopathologic examination or by culture, you have to identify or isolate the microorganism. So identification of microorganism by histopathology or culture is enough to diagnose infective endocarditis. What about the clinical criteria? Clinical criteria we again have divided into two parts. That there is a major criteria and then there is the minor criteria. So what is the major criteria? We divide into three parts. So once again, there is a clinical criteria, pathological criteria. Clinical criteria again into major and minor, and major is again of three parts. The first part is positive blood culture for the organisms we had already mentioned in the beginning. So if you have a positive blood culture for any of these organisms, that is a major criteria. The second one is echocardiographic findings. So echocardiographic finding of either the valvular vegetations or of any abscess in the myocardium, that is considered as a major clinical finding or included in major criteria. And the third one is valvular regurgitation. So new valvular regurgitations are included in the major criteria. What are the minor criteria? So minor criteria includes, first one is fever, high grade fever, and then we have predisposing conditions and IV drug abuse, history of IV drug abuse. And then in addition to that, we had said about the clinical features, right? So any of the vascular phenomena or the immunological phenomena that we had discussed, they all come under the minor criteria. So how many minor and major do we need to diagnose infective endocarditis according to modified Duke's criteria? So we need either 2 major, or if you have 1 major, then you need, in addition to that, 3 minor criteria must be satisfied. So either 2 major alone or 1 major plus 3 minor, or if you don't have any major manifestations, but if you have 5 such minor criteria, that is fever, drug abuse, vascular, immunological phenomena, all of that, if you have 5 such criteria are fulfilled, then you can diagnose infective endocarditis. So 2 major or 1 major, 3 minor or 5 minor. So that's about modified Duke's criteria. Now let's move to the treatment and prognosis. So for treatment, initially we divided into acute and subacute type, right? For the acute, the surgical treatment is required. So you need surgical treatment, valve replacement, plus you initially given antibiotics for more than 6 weeks. Whereas for subacute, usually antibiotics given for 6 weeks is enough. The regimen is not discussed in this video. Whereas for prosthetic valve endocarditis, if it is a prosthetic valve which is usually involved, then you need a surgical replacement of the valve. So surgical repair of valves is required, or valve replacement is required. About the prognosis, if it is untreated, it is fatal. Whereas with good treatments or with early treatments, Streptococcus viridans, about 98% of cure rate is there. For Staph aureus, it's around 60 to 90%. However, if you don't treat, it is a fatal condition. Now, finally, we'll discuss a word or two about other vegetations, which is a short note. So we have 4 diseases which contain vegetations. Our first figure is rheumatic heart disease. And in rheumatic heart disease, what are the features of vegetations? So there are 3 features. First one is their size. They are small vegetations. Secondly, their nature. They are warty nature, and they are stuck to the valves. They do not have a tendency to detach and form an emboli that can get dislodged. And thirdly, their position. They are present at the line of closure of valve leaflets. So line of closure of valves. This is about rheumatic heart disease. Now coming to the infective endocarditis, we have learned about that in this video. Their first point is 3 points. First one, they are friable, they are bulky, they are destructive. And their location, we know, we have said they are mostly located on the left side of valves, and they usually involve the entire valve, the leaflet, the caudate internum, and the whole of valves, and even the endocardium might be involved. The third one, here we have a condition that is known as non-bacterial thrombotic endocarditis, NBTE. So as the term suggests, the definition, that is, it's non-bacterial. So it's a sterile thrombotic, thrombotic vegetation is found. So it's usually seen in hypercoagulable states, right, where a thrombotic predisposition is seen. Now, what are the features? The vegetations are usually small in size, they are bland in nature, and they are attached to the line of closure of valves. And finally, we have the fourth one. There is the lesions that are seen in SLE. Because of the immune-mediated, immune complex deposition, we have a Libman sac endocarditis, which is seen in SLE, systemic lupus erythematosus, which is an autoimmune condition. Now, what are the features? They are medium sized, and their location is, they are seen on both sides of valve leaflet. So that's about the vegetation, and that's in general about infective endocarditis.